You can feel my enthusiasm for the integration of targeted therapy in the treatment of advanced epithelial ovarian cancer. But please be clear, these medications have clear toxicities. And this most important toxicity associated with bevacizumab is hypertension. So we ask our patients to monitor their blood pressure at home. It's complicated, systolic, diastolic. We basically say, check your blood pressure every day at home. And if in the morning the systolic, the big number, is greater than 130, call me. And a significant proportion of the patients treated with bevacizumab will require antihypertensive therapy. We try to teach them to don't feel defeated. This shows that it's working. It's changing the vascularity and, importantly, reducing the angiogenesis in your tumor, and that's why prospective randomized trials show that it's beneficial. But and certainly there's a concern about GI perforation. The GI perforation rate in the use of platinum-sensitive relapse is very low, particularly low in the patients that have not had a recent bowel surgery, particularly low in the patients that do not have inflammatory bowel disease. There's some discussion about bowel surface involvement. That probably is less important. But a patient that's not obstructed, that doesn't have inflammatory bowel disease, and has not had a recent intestinal surgery, the risk of GI perforation is less than 1%. So I don't make a big deal of that, but the hypertension is a real concern. Again, you can feel my enthusiasm for targeted therapy in ovarian cancer. I wanted to discuss with you the toxicities of PARP inhibitors, though, because like every treatment, whether you call it chemotherapy or not, whether it's maintenance or treatment, and maybe maintenance is treatment, there's side effects. And the side effects of PARP inhibitors basically are similar across all three. And the first important side effect that we can manage proactively is intestinal toxicity, nausea, vomiting, diarrhea. So we start everyone on a proton pump inhibitor. Even probiotics is sometimes helpful. And we tell them to have an antiemetic available, not a piece of paper, but a tablet, that if you get nausea, to take it. Same with an anti-diarrhea medication. If you have some loose stool, take it. And if you continue to be symptomatic, despite supportive care, stop and hold and recover. Stop, because it's all about survivorship. GI toxicity, number one. Number two, bone marrow side effects. And for niraparib, that's predominantly platelets. Thrombocytopenia, we've learned, though, that in the patient who is underweight, maybe less than 70 kilograms, and maybe has a low baseline platelet count, maybe less than 150 at the time of initiation of niraparib, that the dose is probably 200, not 300. So we've mitigated the thrombocytopenia associated with niraparib. There's also some cumulative anemia. Anemia is relatively easily treated with blood transfusion. We generally don't hold for anemia, but we do hold for thrombocytopenia. We do hold and recover for GI toxicity. The third toxicity of PARP inhibitors is fatigue. And when a patient has fatigue, they need an evaluation. I'm here in the desert. The most common cause of fatigue in Arizona is not a PARP inhibitor, it's dehydration. And I bet you're fatigued today, and you're not fatigued today because of PARP inhibition, you're fatigued because you lack sleep. So when a patient is fatigued, they require a comprehensive evaluation, which includes hydration, depression, sleep, hypothyroidism, anemia. Okay? So I want you, when your patient's fatigued, to evaluate them and treat the appropriate cause. So with appropriate symptom management, we can manage the GI toxicities, the bone marrow toxicity, as well as the associated fatigue. But we have to be aware that although PARP inhibitors are oral medications, they have associated toxicities. We need to be aware of them, and we need to be proactive.